The people with learning disabilities who are in hospitals, roughly half of those individuals are in assessment treatment units. The other half are in actual hospitals under a section of the Mental Health Act, known as secure hospitals. And in a sense, it's important to nuance that to only to a certain degree, because the outcomes in both are actually not good for the individual. And the problem is that the outcome is the longer you stay in either, often the worse the situation becomes for you. Not just in terms of how difficult it might be for you to go back, but actually you as an individual start actually deteriorating in terms of your health and mental well-being and all the rest of it. So the outcomes are not good. One of the reasons for that is actually the interventions over a period of time. Actually, they're actually not that expert. So even though you'll have specialist hospitals who are say that they are supporting people on the autistic spectrum, you will often find that actually they will not have expertise to do on the autistic spectrum, despite the fact that they will be extraordinarily high-watering expensive. And I was actually quite shocked by that, to be honest. Therefore, the lack of what you would expect to see in a fairly normal community-based facility, house or even school, you would not see within these specialist hospitals. And staff would not be signing, did not have training in autism, etc. So I think there are lots of questions around where does the money go and what is the expertise. Now, I did see examples of very, very good assessment treatment units, one of which was in Leicester, where they had actually moved they reduced the average length of stay for somebody who went into assessment treatment unit from 21 weeks to 3.5 weeks. 3.5 weeks is assessment and treatment. That is somebody who's in a very distressed situation, family's a very difficult situation, and they do a lot of good for them, and they get people out very quickly. And they did that extraordinarily well, very intensely, very high expertise. They knew what they were doing. That becomes very different when it starts moving into much more longer term and the rest of it. Now, the distinction in the other hospitals, if somebody has committed an offence which has gone through a court of law, and the court of law has passed a sentence on somebody, that puts them in a very different scenario in terms of they're serving their sentence in a hospital rather than in a prison. And one could argue it may, even though those hospitals are not good, they could still be better than the prison. So there is a nuance there, but nonetheless that's still very much the small minority. So I am concerned about the rebadging, I am concerned about the quality. One thing which the NICE, I don't know if many people have heard of NICE. NICE is the National Institute of Care and Clinical Excellence. And you may occasionally hear about them on the newspapers because they make decisions around drugs that people might have if they've got cancer or whatever, whether these drugs are that should be paid for by the NHS and whether they work for you and all the rest of it. They do a lot of other things. One of the things they look at are quality standards of medical treatment, quality standards, and beginning to quality standards of social care. One of the things that NICE is going to be looking at is the model of inpatient support for people with learning disabilities in these units, to try and come up for the first time ever. Actually, there is no standard, there is no kind of quality sort of framework around this that is standardised. They tend to form around actually what the individual clinicians themselves might want to do. So they want to look at both that and also actually what are the clinical outcomes. What is it that somebody somewhere is funding, should be expecting, never mind the individual themselves and their families. It's not clear, and actually some of that would therefore come in terms of quality standards. At the moment they fall under just the normal generic standards within CQC, which are not as nuanced as you've just described. So there's a lot of stuff there. I think the issue around rebadging, people were concerned that actually what we would see instead of assessment treatment units would be large hostel type provision, again, residential care homes. And there is some evidence of that, but there's not as much evidence as people are fearful of, which I'm pleased to say. I will say, though, having said that, a hospital's a hospital, and they can't be anything other than a hospital. If they're registered as a hospital, they're registered as a hospital. As a registered care home, you're a registered care home. They are very, very different. You cannot pretend one is the other these days, but you can still have quite institutional provision within a registered care home. And I think some of that kind of goes back to the challenge which is still there for commissioners as well as for providers, but certainly for commissioners, because somebody somewhere is always paying. No provider does anything for nothing. And so somebody somewhere continues to pay. And so while somebody somewhere continues to pay, I'm afraid those things will happen. So there's a double issue there. One of the things I'm really delighted around with the NHS England response to the Bubb report actually is it's kind of woken them up, because what was happening was NHS England were funding more than half of the individuals through this different type of their own, called specialised commissioning. And that bill was going up. Surprise, surprise, because if a local area could get somebody else to pay for it, well, why wouldn't they? Let's face it. And so, NHS commissioning was kind of a bit asleep at the time around this, and the numbers kept going up. And surprise, surprise, because somebody else then had to pay for somebody to be discharged, they weren't holding up their hand too quickly and say, yes, please, can they come to us? Because while you're paying. So that was a real challenge. So finally they've woken up to that, and they're doing something about that, which I think is great. And it will cause the sort of stimulus that Richard has suggested. But having said that, I think the challenge still is that when you actually get to individual, because one of the things I was very keen on is that we make this on an individual type program, and area by area, so each area having its own plan around each individual within their area, so really microise it to make it work. When you do go on an individual level, you do have some very, very complex situations. And therefore you have to have arrangements. The areas that we're doing best were those areas that trusted each other, that got people together in rooms, and they kind of really problem solved, and they didn't shove the problem between each other, and they were really working this thing through, and that is particularly important. So it's not just about the flow of money, it's around the sharing of the risk, it's around the clinician who's making a decision on behalf of somebody in terms of what that risk is, and on how the procurement team in the county hall or the city hall is then sort of engaging with the process, and it actually requires a real joined up sort of area-wide, person by person type of approach. And there are lots of examples who do it very well. There are far too many examples of where it's not happening. But the new party to all of that really is NHS England engaging with that. And I think that to me is going to be the solution is. And because at the moment the hostels or the hospitals, they are based on the fact that because people won't do that, individuals will keep falling through the cracks, and they become the ready solution.